Thanks to everyone who's coming on and joining us. We will get started in a couple minutes. We're just giving some time for all our participants to hop on, so thank you. Thanks to those who are just joining us. We're going to get started in one more minute. We're just giving some time for everyone to join. For folks who have asked about video recordings, yes, we're in the process of recording, and we will be able in the future to make those available to everyone. So thank you. Thank you, everyone, for joining us. We are going to get started, so if you're just coming in, you haven't missed anything yet. So good afternoon and welcome to episode 10 of the COVID Ethics series, Stop Killing Our Patients, Pandemic, Protest, and the Outcry for Justice. My name is Bryan Pilkington, and I teach ethics at Seton Hall in the Con, Shims, and at the Hackensack Meridian School of Medicine. This event is a collaboration with IHS Student Engagement, and a special thanks to Kelly Freeman for all of her work to facilitate student questions. This session has been motivated by our students, especially a number of students in the medical school who have asked for this and sent us questions. Also thanks to Mark Schwartz and Aaron Taylor of HMH and the med school respectively for coordinating the logistics, and Allison Piazza for working with us on our library webpage. To those who joined last week and those who tune in regularly, welcome back. For those joining us for the first time, each week we take up ethical questions that have arisen or intensified due to COVID-19. I'll speak with a panel of experts, then turn to your questions, which can come in via Zoom, the question or chat features, or via our Twitter handle, which is @ShoeBioethics. And again, a special thanks to the students who have submitted questions and pushed for these important conversations to begin and continue. Today, we build on themes from previous sessions on vulnerability and discrimination. And I'm grateful for the work of Samson Davis, Lynette Martins, David Kuntz, Casey Choi, Tade Ayeni, Nancy Berlinger, and many others who have had those conversations with us over the past few months. Today, I'm very happy to be joined by Dean Bonnie Stanton, Professor Kirk Johnson, Professor Solangel Maldonado, and Dr. Douglas Finnefrock. America faces two public health crises, the COVID-19 pandemic and the continued manifestations of structural racism exemplified by the most recent series of murders of Black members of our communities. The conversation today will touch on concepts like weathering, white fragility, race-based medicine, discrimination, and teaching during this time. We're under no illusion that any of the questions embedded in the long history of racial injustice will be sufficiently addressed today, but we hope to add to these conversations regarding what has led to structural injustice and what healthcare practitioners, others, and especially students can do about it. I'm now going to turn to our panelists, and I begin with our first panelist, Dr. Kirk Johnson. Kirk is an ordained clergy member in the United Church of Christ, an adjunct professor of religion at Seton Hall University, where he's also an alum, and there's a whole list of other features which are on the slide now that I won't mention from Kirk. I do have a prop, Kirk, as we chatted about. Kirk is the recent author of Medical Stigmata, and I have my copy here, which is an excellent book I recommend to all of you. So, Kirk, I was wondering if you could start the conversation off for us in light of your recent book on race-based medicine and all of the work you do in bioethics and religion. Could you help our students and the rest of us think through some of these issues?
Yeah, of course. And first, thank you for inviting me, and happy Juneteenth to everyone. Of course, today is an important day within African history, African diasporic history, regarding the physical freedom of individuals who look like me. So happy Juneteenth, everyone. Well, the first thing is that we have to consider the concepts of race, the constructions of race. So a little bit about my book, which I know people ask me to talk about. It explores the origins of race and the constructions of race. And then it explores and examines how race has been used as a weapon by the medical establishment, by American society, by the pharmaceutical industry, even well into the 21st century, on vulnerable populations, on individuals who are considered people of color, communities of color. And how do we respond to that? Well, first, the medical establishment needs to acknowledge the histories of eugenics, which I don't think has nationally or formally been done. I actually don't think our federal government actually has acknowledged and apologized for the institutions of slavery. And because of the lack of acknowledgement or the ignoring these particular historical truths, unfortunately, the sins of our country, also connected to Native Americans, we still see in 2020 these issues that continue to permeate not only in the medical establishment, but in employment, in healthcare, in insurance, in economics, in real estate, and so many other factors of American life. So what can we do? Well, first, in the book, I mentioned about the theological elements of this, liberation theology, meaning how do we help individuals who have been historically disenfranchised to be liberated? Well, religious institutions, specifically the church, can help in that. Of course, historically, hospitals have been started by churches, and it was a form of liberation, not just spiritually, but also physically and mentally as well. There are many different initiatives that medical schools and churches, mosques, temples, all forms of religious institutions can participate and partner in order to alleviate the many facets of the social determinants of health that plague minority communities. One example is having a health fair, right there, whether you're Jewish, Muslim, Christian, Hindu, Buddhist, wherever you worship, that place could be a source of not just spiritual liberation and spiritual connection with the divine, but also it could be a partner with your local hospital to maybe once or twice a year have a health fair where people could get free temperature checks and free resources that could educate themselves regarding health literacy, right? So of course we could talk about a lot of the problems, but the problems are going to continue to exist unless we do something about them. And really having partnerships and being unique and creative and having partnerships that we haven't had partnerships before, I think is a great way to start alleviating the health inequities and the health disparities in minority communities. So these are just different elements that I talk about in my book, but also are practical, right? In ways that we could systematically, slowly but surely change all of the different ills that racism has really implored on in regards to communities of color.
Thank you, Kirk. That's very helpful in sort of laying out some of the background and sort of the work you're doing on race-based medicine in the book. I'm going to move now to our next panel. I know there's a number of questions I have for you and a number of questions from our students, but we'll get going through the panelists and then we'll return to you. So I'm going to move to our next panelist, Dr. Doug Finnefrock. Doug is the Vice Chair and Residency Program Director at Hackensack University Medical Center, Vice Chair and Associate Professor in the Department of Emergency Medicine. And Doug, I know you've been doing work in this area, recently building, as a professor in the medical school, some of the HD cases around topics. So I was wondering if you could share with us sort of your experiences and sort of help our students and the others on joining our conversation to think through some of this from your perspective.
Sure. Thanks, Brian. And it's really great to be here and really great to be on such an esteemed panel and learning so much from everybody. It's really hard to process what's really occurred over the last few months. On one hand, we had a pandemic, which was a change that none of us needed. And in particular, in these moments, as we have an acute focus on race, we now have a change that we do need. So much has happened in a short amount of time that's leading to this good point for us to be here and make change. I want to first off say that I'm not the expert. I'm definitely not the expert, but what I can share is my process of listening and my process of learning. I've reflected upon my experience personally. I think back to some of my early experiences with race relations. And I think back actually my experience, first of all, in playing organized sports, and in particular playing team sports, having Black athletes who were friends and teammates. We trained together, we worked hard together, we won together, we lost together based on how well we played as a team. And that sort of influenced things early on. But more recently, I've really turned to my colleagues who are Black and my friends who are Black to be able to attempt to better understand things and be able to be in their shoes and understand their perspective. Something that was suggested to me in regards to resources was a book that I'm recently reading by Robin DiAngelo entitled White Fragility, Why It's Hard for White People to Talk About Racism. And she coined this term in 2011. Essentially, the term white fragility means a discomfort or a defensiveness by a white person when confronted with information about racial inequity or injustice. And there are 5 key points that I was able to take away from this particular book. First of all, it suggested that whites abandon the idea that racism is necessarily just about being moral or immoral, being good or bad, but accept the fact that we have unconscious bias. And that doesn't necessarily make us a bad person if we have unconscious bias, but to recognize it and not ignore the fact. To seek perspectives from others, particularly others from different ethnic backgrounds. But do this for yourself. Don't do this for your friends or colleagues from those other backgrounds. Do not deny that you see racism in your daily life and that you see it around you, not to deny that. And finally, the idea that this can and often should makes us uncomfortable. I learned something from a leadership program that Steve Adebato, who's on the local PBS and actually a professor of communications at Seton Hall, told us in regards about change. Change and progress occurs at a time when you push yourself out of your comfort zone. So when you're uncomfortable and pushing yourself there, that's when change can happen. And I think that's something that many people are experiencing now, which I hope is a good thing. And then moving on to our students there, our healthcare providers, our healthcare students, some things to think about what you can do, not only in your personal life, but in your professional life. The most obvious thing is be a tireless advocate. Be an advocate for your patients, starting with your patients. But it does require, and I think the best doctors are the ones who can put themselves in their patients' shoes the best. Think about, as we talk about race relations, also in the context now of COVID and this pandemic, we're talking about an environment now where our communication is with masks. So trust in and of itself is challenging, in particular, if a patient or family member has not had a good experience in healthcare. For them to be in the middle of a healthcare concern and within a hospital, and now communicating with masks poses a greater challenge. So be empathetic to that and recognize that. Look to the leaders around you that you have. And for our medical students in particular, all are familiar with the incredible program of human dimension that Dean Stanton brought as her vision. And her vision truly was to be innovative in the way that we connect our students with the communities and to collaborate with community resources so we can improve the health of vulnerable populations. That's the goal, and that's still a central goal for our medical school. You have wonderful people, some people that Bryan mentioned in the introduction. You have a new faculty member, Dr. Tade Ayani, who's our Director of Diversity and Equity. And I can tell you I've had an opportunity to collaborate with him in writing some cases where we do focus on what we can do for vulnerable populations and how we can work on building trust. And he's been remarkable. Another remarkable person I think you may know is our Dean, David Kuntz, who's our Associate Dean of Diversity and Equity. Just this morning, he gave a wonderful acknowledgement to all of our Dean's cabinet, our chairs, our vice chairs, and our clerkship directors, recognizing the importance of today and also recognizing the fact that this is now the opportunity for change. And he even offered a series of information he has in regards to microaggression in the clinical setting. So we're very fortunate to be in a community where we have a lot of wonderful people to learn from, and just fortunate to be here. Thank you.
Doug, thanks very much. And we're going to now move, well, like with Kirk, we have a ton of questions coming in, so we'll get back to you and sort of continue our conversation. But I'm going to move next to Professor Maldonado. Solangel Maldonado is a faculty member in Seton Hall School of Law, as well as a member of the American Law Institute Restatement of the Law and Children and Law reporter, and on the editorial board of Family Court Review. Professor Maldonado, thank you for joining us. I know that you do a great deal of work on race and the law, especially as it applies to families. And I know you've also been thinking about and doing some work on the concept of weathering. So just want to open it up to you, like the other panelists. Help us think through some of these issues, please.
So thank you, Bryan, for inviting me to participate on this panel. I'm actually going to be pretty brief because I am most interested in hearing how students are thinking about these issues. So as a lawyer and a law professor, I think about these issues, I think about everything I think in life through the lens of law. So I want us to think about, how the law created the racist society that we live in, how the law maintains that system, and how law is one of the mechanisms that is necessary to cure the effects of our racist society. But first, I think it's really important that we understand what the protests, and yes, the riots as well, are about. We see all of this in the news, and maybe we've participated in some of these protests ourselves, but my sense has been that not everyone understands, what it is that people are protesting. It's about police brutality and, of course, the unlawful killings of African Americans, but they're also about centuries of racial oppression that African Americans and other racial minorities have endured in the U.S. It's impossible for those of us who have not lived the African American experience to understand the anger, the fear, and the sadness that many individuals are experiencing. So I thought that I would share with you a very powerful statement that Dean Angela Wachi-Willig of BU, Boston University Law School, recently shared with her students. So if you'll just indulge me. So in her statement, she starts out by saying, for the past week, I have woken up each morning with an indescribable pit in my stomach and a paralysis in my head and my body. I've had to force myself to fight against this paralysis each day just to get up and face the loads of work that must be completed. And then she says, this pit in my stomach has been festering for decades, finding itself repeatedly punctuated and reignited by a cycle of direct state violence, as well as state condoned through inaction violence against Black people. And then she goes through the list of the names that we are all too familiar with now: Rodney King, Trayvon Martin, Ahmaud Arbery, Breonna Taylor, and so forth and so forth. And then she goes on to write, and I'm quoting again, "I am the mother of 2 Black sons and 1 Black daughter. I fear for their lives whenever they step outside. As the mother of Black children, I both envy and resent the freedom with which mothers of white children parent. They will never have to balance that delicate line between teaching their children how to ensure their survival after a police stop and crushing their spirit while doing so, because the very lessons derived from another, that Black lives are not valued in our society." And she adds that African Americans are dealing with all of this on top of the brutally disproportionate impact that the coronavirus has had on Black and Latinx individuals, particularly those who are working on the front lines of low-paying service jobs without the same acknowledgement and praise that we have reserved for doctors and nurses. And so I was struck by this intersection of the coronavirus and violent acts against African Americans. Also, when I heard Professor Paul Butler at GW testify recently, I forgot where he was testifying, but he mentions that when one of his students, an African American male, said he was going to a protest in DC, Professor Butler said to him, "Well, make sure you have PPE because we are in the middle of this coronavirus." And the student said to him, "Professor, I understand that, but as a Black male, I have a much higher likelihood of dying at the hands of the police than I do as a result of the coronavirus." And statistically speaking, he's correct. So I'm sharing Dean Awachi-Willig's statement and Professor Butler's anecdote with you to impress upon you just how much trauma the African American community has experienced and is experiencing, and to ask you to think about how you as healthcare professionals would treat someone who has suffered severe trauma. Would you judge an individual's, how that individual reacts to trauma? Would you bring in law enforcement when a person who has suffered trauma actually seeks treatment? Probably not. But my African American students who organized the vigil a few weeks ago in honor of Black Lives Lost to Violence described preparing to go to a protest as preparing to go to war. And this is actually a very apt description because we know that protesters have been targeted with chemical weapons, tear gas and pepper spray, which of course lead to coughing and eye tearing and thereby increasing the risk of community transmission. So I ask you to think about, why is it that given the trauma that African Americans have experienced, why is law enforcement our first line of defense? So I just want to talk about law for a moment. So many people believe that the law is objective and that the law treats its citizens equally, but that is simply not the case. The law itself created a system in which African Americans and other non-white groups have been subjugated, and this system continues to this day. And just to give you a couple of examples, so New Jersey is one of the most segregated states. I believe it actually may be the most segregated state in the country, but I didn't have a chance to make sure that that's still the case. But this did not happen accidentally. The segregation that we see in our state was the result of government-sponsored housing segregation around the country, and specifically New Jersey. And so these legal policies actually kept African Americans from buying property in white neighborhoods. The huge economic gap between African Americans and other minority groups and whites is also the result of government policies that favored whites and provided assistance to white families, but denied such assistance to minority families. So this summer, I would urge you to read 2 books by historians that do an amazing job of describing this history. One is The Color of Law, A Forgotten History of How Our Government Segregated America by Richard Rothstein. And the other one is When Affirmative Action Was White, An Untold Story, Untold History of Racial Inequality in 20th Century America. In addition to these policies, the law has also contributed to a police culture in which police officers have historically used excessive force and abused their power with impunity. So given the law's creation of this system, I want us during the Q&A to think about what are the legal remedies, and specifically how the law can actually borrow from the medical profession, and how these remedies will actually require more, that healthcare professionals, play a larger role, do even more than they're already doing in our society. So I'm just going to sort of list two, or tell you about two of them right here. One of them, which a number of legal scholars have been calling for, is for us to create an affirmative duty on police officers to do something when they see something. Meaning, right now, police officers do not face any civil liability when they observe a fellow officer engage in an abuse of power, as we saw in the murder of George Floyd, that other police officers stood around and did nothing while one officer killed George Floyd. But in the medical profession, as I understand it, I'm not an expert on the medical profession, if a doctor or a healthcare professional sees another professional who is engaging in a harmful act towards a patient, then that person has an affirmative duty to do something. Well, how about creating the same duty for police officers? The second thing, which you may have heard a lot about in the media, is that we are actually asking police officers to do way too much. By that, I mean that we are asking officers to engage in tasks that they actually do not have any training in. Specifically, we're asking if there is substance abuse, who do we call? We call the police. Well, why are we calling the police in these cases? This is a job for healthcare professionals, for substance abuse professionals, for mental health professionals. Another example is 1 out of 4 people who have been killed by police have had mental health problems. And so we should be calling in the mental health care professionals to help de-escalate these situations, instead of asking police officers to do so much. So I have a number of things that I believe all of us can do to sort of think through about these issues and how we can help. So I'll just tell you just maybe one or two, and I think my co-panelists have already mentioned this. One is, let's actually take racism seriously. When Black and brown people tell you that they have experienced racism, do believe them, believe us. Do not attempt to sort of minimize it or think about it as a misunderstanding or suggest that they are overly sensitive. But even in the absence of video, take allegations seriously. Just like mental health professionals, when a patient comes in and tells you what they are experiencing, you take that seriously. The other thing that I would like to emphasize is just the importance of educating ourselves. I'm not exempting myself, although I'm a woman of color, an Afro-Latinx woman. I definitely have a lot of learning to do as well. But let's all educate ourselves about the systems of oppression in our society and how we are complicit in these systems, not necessarily because we as individuals created them, but because we do benefit from them. And related to that is all of us, have a responsibility to recognize our privilege, whether it's race privilege, class privilege, and to use that to fight oppression and racism. So I'll stop there, and I look forward to your questions.
Thank you, Professor Maldonado. The sort of breadth of the approach and the challenges, the way you framed that was very, very helpful. And for folks who are calling in, we do have our resource center. Some of those will be offered. Some of them are housed. And we will put the 2 books, links to the 2 books that Professor Maldonado mentioned there, as well as, of course, Professor Johnson's book and other resources we have. So I now want to turn to our last and our final panelist, Dean Bonnie Stanton, who's the founding dean of our medical school and professor of pediatrics. She's an endowed chair in the medical school at Hackensack Meridian School of Medicine at Seton Hall. Bonnie, it's great to have you here. The big question for you, picking up on what our other panelists have said, Professor Johnson noted sort of the importance of considering within medicine the social determinants of health. Dr. Finnefrock has sort of highlighted this as well, and why the medical school is embedded in the communities in which it is, and sort of the breadth of the challenge was laid out well by Professor Maldonado. So for those on the call, for our students, can you help us think through this as someone who leads a particular kind of medical school?
Well, thank you very much. And I give all the people in the audience a warning. You don't want to be last in line after Dr. Johnson, Dr. Finnefrock, and Dr. Maldonado. Those were all wonderful, wonderful talks. I was quite intrigued by Bryan's question. And so I looked back sort of historically through my career and things that I picked up and then ultimately brought to the forming of the new medical school. And I use the verb forming because that is exactly what we were doing. And we are so appreciative of all the inputs that our current and our future students, we hope, will continue to give us so that we are now building this medical school as a group. Throughout my career, since I completed residency and fellowship training, I periodically look back to assess, am I proud of what I and my former medical school colleagues from across the nation have accomplished thus far in the medical sciences? And I try to look at this from different perspectives. Overall, in comparison to what's happening in our peer nations and what is going on with science and research there, and by population groups within the United States, are we all benefiting equally from whatever good the medical profession is doing? And I urge those of you, again, in the audience, the students, to learn not to become complacent. Don't assume that because things are okay, they shouldn't be better. And so challenge yourself every 5 to 10 years. Doesn't mean you have to leave your job, but it does mean you might want to change the focus or change the infrastructure about you. Overall, the US, I think, has made major contributions to the world's scientific fund of knowledge. I had the really good fortune of growing up in the magnificent era that started in the 50s and probably went through partway the 60s of discovery for the sake of discovery. It's a beautiful concept, and it so often leads to very exciting, perhaps unanticipated findings, whole new ways of looking at and solving daunting problems, a way in which a scientist's approach to the world is really quite different from that of many, if not most, other professions. And as a result, we've enjoyed so many advances during my lifetime, none of which I'm mentioning that I had anything to do with other than be the recipient. One of my first memories is I remember as an elementary school student standing in line with all the other students in our school to receive our very first polio vaccine. And with that polio vaccine, we so changed childhood across the world, certainly across the US and largely across the whole globe, although as we all know, there still are some areas where we have not been that impactful. I remember as a teenager, the excitement about the advances in cancer treatment and their stunning impact on childhood and adult morbidity and mortality. Although still, by the time I did my residency, so many children were still dying, and those deaths no longer occur. We enjoyed massive leaps forward in our ability to visualize organs within a live human being, and you know, this whole notion of ultrasound and so many of the other non-invasive ways of looking, MRI, CTS, etc. And I could go on for hours citing the major breakthroughs by US scientists in the field of medicine and their remarkable impact on disease-specific morbidity and mortality. In fact, so exhilarated by this sense of all that the US had accomplished in terms of the scientific breakthroughs, it took me a decade or so before I began to realize how poorly so many nations across the globe were still doing in comparison. And in fact, it was that realization that we were living in a magnificent, isolated area in the US that prompted my husband and I to decide to move to Bangladesh for 2 years which turned into 5 years, to address several of the causes of the astronomically high infant and childhood mortality and the very low average lifespan amongst Bangladeshis, who only at that point had been an independent nation for about 7 or 8 years. So during these 5 years, I focused on diarrheal treatment and prevention among slum-dwelling families in Dhaka, Bangladesh. And that was my first exposure to a community orientation, a community vision of problems. Even though I was still looking at some of these problems in the office, by and large, I was out in the community, and I began to appreciate how important it was for physicians to really understand what is and is not available in the community. When we returned to the US in the late 1980s, the HIV epidemic was racing forward. In contrast to its demographic focus at the beginning of the epidemic, it was now disproportionately impacting low-income, urban-dwelling African Americans. So beginning in the late 1980s, HIV among inner-city African American youth became and remained, until I came to my current role, my research and my academic focus. And there is when I really fell in love with the community. And I think I realized that it was very hard to imagine being a physician without understanding the community. And I have endless, and I'll only say one very quickly, anecdotes about the process over time where it was clear that this affection and this trust became mutual. So in the 1990s, of course, we didn't have cell phones, and I was an active practicing pediatrician. And so I had a beeper, and when my patients needed to get through to me, they would beep me, and I would look for the nearest payphone. And eventually, I became I had an odd friendship with a group of young men living in the inner city, and they were drug dealers, and they would be clustered around the telephone. But when they heard my beeper go off, they'd say, "Get off the phone. Dr. Stanton has to make a call to find out what's going on with a patient who might be one of our kids, so let's let her have the phone." And it was, at first I was quite uneasy with it, thinking, but I shouldn't be friends with these people. And over time I realized, as we all learn, that yeah, there might be some things that are going on that aren't great, but you can form wonderful partnerships with very important constituents of the community. As I advanced in my career, I became increasingly aware, though, of the rapidly declining health performance, including life expectancy of Americans compared to persons living in other nations. And the medical students are familiar with my talking about this, so bear with me. Life expectancy at birth in the industrialized nations as a group in the late 1960s was 70 years. By 2015, it had increased to 80 years, a gain of 10 years. In the US, life expectancy in the late 1960s was 71 years, 1 year longer than the average of all the industrialized nations. In 2015, it had increased by only 7 years, leaving US life expectancy at only 78 years, 2 years shorter than all the industrialized nations' average of 80 years. So life expectancy then went on to decrease in the United States in the years 2015, 16, and 17. And it did this without a major illness. This sustained decrease of that magnitude of 3 years in a row has not happened since the Great Flu Epidemic in 1916 to 1918. And yes, of course, we're all thinking the same thing. What will the pan epidemic do? What's especially troubling, though, about this overall data is that it's so demographically uneven. In the US, except at the very oldest ages, African Americans have the highest death rates of any of America's racial and ethnic groups. The racial differences in mortality persist even in studies that compare individuals with similar levels of income and education. The disadvantages for African Americans appear for all the major causes of death. And of course, now we know that African Americans are at disproportionate risk for dying from COVID-19. Over the last 20 years, when I was involved in groups working on the mission and vision statements of schools that I had been at prior to arriving here, I often puzzled that we did not specifically call out the need to focus on our most vulnerable populations, but for whatever reason, we did not. Therefore, when in January of 2016, I received a call from the head of the search committee from representing Seton Hall University in Hackensack, at that point not yet Hackensack Meridian, to ask if I'd be interested in interviewing for the position of the founding dean of their Envision School of Medicine. And so I agreed to come to interview. And during my interview process, I explored their intentions and focus. In finding it to be so very consistent with my visions and expectations, I accepted the position with joy and excitement, and it is still the same joy and excitement that I feel being here. And over the next several months, we put together a leadership group whose first charge was to articulate our vision. And so our vision, as many of you know, but not all, is each person in New Jersey and eventually in the USA, regardless of race or socioeconomic status, will enjoy the highest levels of wellness in an economically and behaviorally sustainable fashion. And yes, for those of you who mentioned it, the rock bed of that is our Human Dimension project, our community-based research project or education project. So thank you, Bryan, for inviting me to this really exciting seminar. And now I look forward to the questions.
Thank you, Bonnie. Thanks for the comments. They're very helpful. And the humility with which you approach these questions and your examples of growth through the process, I know are an excellent model for all of our students and for all of us. I want to direct the first question to Professor Johnson. So because we're thinking, and we have many, many questions from students, we get these every week about what can we actually do? And we've had the starting or the beginning of some of these answers. So what can we do in response to challenges? In your book, you note that the Black church is uniquely placed for some sort of considerations and responses to race-based medicine and more generally. And what you cite is an opportunity for dialogue within medicine, theology, and a few other areas. So I was wondering if you could just sort of speak for a moment about how you see dialogue about the unique role of the and about the unique role of the Black church.
Yeah, well, first, in the spirit of Dean Bonnie, we have to approach this with humility. You have to have emotional intelligence. You have to be aware that you have your own biases. Every single person has their own biases, and you have to confront that and be honest with that and be humble about that, and not, as Dr. Douglas said, right fragility, not to be scared, not to feel guilty, but confronting those things and realizing that you have to be uncomfortable. If you're white, you have to be uncomfortable in order for change to occur. And don't take it personal, right? It's not one person's fault that we inherited this mess called systematic racism. And connecting that to liberation theology, we are the Imago Dei, right? We are all children of God. We're all shaped and molded, different colors, different hues. We are all significant in the eyes of God. And we have to show that not amongst people that look like us, but also people that do not look like us as well. For example, Asian Americans right now, and I have to say this, are also being targeted because of COVID-19. Right, racial epithets of the Chinese virus, right, the Kung flu, always is deeply rooted within, of course, Chinese and Asian American history of their struggles for racial equality as well. And there are tons of New York Times articles of Asian doctors who have been mistreated, who were turned away by patients because of their particular, the ways they look and their particular culture, ethnicity, and origin. So we have to be humble and actually say, you know what, I do see color. Get rid of that, the fallacy of color blindness. Color blindness doesn't solve racism, right? You have to see color and acknowledge diversity and welcome diversity and say that this is something that isn't a threat or is something that is diminishing or diluting American society, but it's actually enriching American society. How boring will it be for everybody to look the same, right? And everybody have the same background and same culture. So it's really under the umbrella of loving your neighbor, loving God with all your whole heart, soul, and mind, and also loving your neighbor as yourself. And now, again, that is through humility and through self-awareness and self-purging of biases that we have. Now, how can the Black church help? Well, first, as I said earlier, reach out to the NAACP, right, which is deeply rooted and connected with the Black church. Hospitals should reach out to Black churches in their neighborhoods, wherever they are, to say, hey, what can we do to be a resource? We have a lot of foundations and grant programs who really could benefit having grant writing within churches, right? Having pastors or senior pastors of churches to actually be a part of a particular program where we could get congregations involved regarding their own personal health, right? What challenges they're facing within their communities. We also have a national initiative. I know the National Baptist Convention, USA Incorporated, has a HOPE initiative, which stands for the Health Outreach Prevention Education Initiative, where they're trying to create health ministries in churches, right? So how can medical schools, how can hospitals, how can doctors and nurses, sometimes who are members of these churches, create health ministries to target the different issues or the different health issues that the congregation is facing? High blood pressure. Maybe we need to partner with the American Heart and Stroke Association if heart issues is prevalent in your congregation, right? So again, it's really about rethinking partnerships and creating new partnerships in places that we haven't really thought about creating partnerships before. And I think that is extremely important in starting that particular dialogue in alleviating health inequities in communities of color. So these are things that are tangible, that are practical, and really it's just a conversation starter. Reach out and have a conversation and develop a plan, short-term and of course long-term, within communities of color and within churches of color. And that's the history of the Black church. Through Booker T. Washington, for example, he created the National Negro Health Week. This is also in my book, and partnered with churches to have different months that are targeted for health issues. So say this month is June. This month we could talk about diet and exercise, right? Maybe we could invite, have Bowflex or a Zumba class or something of that nature within our church congregations, right? I mean, it's really about being creative and finding new ways to not just use the church or any religious setting just as a spiritual center. Churches could also be turned into a mental health center, right? As you talked about the drama or the trauma of racism, that is also psychological and mental for people of color. Maybe we need to get therapists and psychologists in churches to actually talk not about the spiritual element, but also the psychological and mental fatigue that racism has on a daily basis, right? So these are just different ideas that we could explore, and it could really be tangible and effective for communities of color.
Thank you, Kirk. Very helpful in answering the question and rooting things within the Black church. You also managed to answer a number of other student questions, especially about colorblindness and sort of the challenges of understanding racism in that way and the problems with it. We have a few questions specifically that have come out of our medical students, but I want to expand it to ask our panelists to consider all students. So I'll start with Dr. Finnefrock and Dr. Stanton, and move it beyond to the rest of the panel. They've written and asked about how they themselves as students can speak up about experiencing ingrained racism in our medical system. So, and I want to couple that with a few other questions about how to respond to racism that you see affected toward your colleagues, and sort of how to properly be an anti-racist. So the question has two parts about what students could do to speak up about racism that they've experienced, specifically medical students, but beyond, and then what others can do as well.
Sure.
Yeah, so Doug, if you have any responses to either the first part of the question, the second, otherwise I'll just work through the panelists.
Absolutely. So I think, I think there are moments in healthcare, and stress in particular can bring out the best in people and the worst in people. And I remember training in emergency medicine. It was 20 years ago when I was an intern. And I think early on, what I didn't recognize is that at those stressful moments, there could be, and there has been, conflict. And so in particular, I'm thinking about a scenario of a patient that would predominantly be Black or brown and, say, sickle cell anemia crisis, and a conflict that occurs when there's a disagreement between the healthcare team and the patient in regards to what the appropriate management is and pain management is. And sometimes I've certainly seen the worst of moments of stress where that ends up with a conflict, that ends up with a disagreement, and that often ends up with the patient doesn't trust and pulling out the IV and leaving. And so, so what I didn't appreciate early on that I'm learning to appreciate better now is the context of this and the importance of trust and what the previous experience had been for the patient. So if you're a student now and you see a conflict, you participate in a conflict, it's easy to be conflict averse. And the easy thing to do is say, okay, here you go. Let's both walk our separate ways and let's move on to the next patient. But to have the ability to empathize, first of all, the ability to apologize. As Dr. Johnson said, there's a lot of things that have happened. We should apologize. And apologizing doesn't mean that you personally did something wrong and that you personally are saying that you're a racist individual. Apologizing for the context of the healthcare environment and for perhaps previous experience that may have occurred. So being able to apologize, being able to calm, to connect, and to recognize the reasons for stress is automatically the first step. And then going from there, we're hoping to have the goal to be empathetic, to be able to put yourself in their shoes, and then work together on the plan. So I've taken it upon myself to find those stressful moments and really challenge myself to work on the service recovery and work on establishing that connection and that trust and trying to move ahead. And I found those to be, when it's successful, some of the most rewarding interactions with patients, in particular in the emergency department. And, so I challenge the students to do that as well and have these conversations with the residents, with the attendings. And if you hear some discussion that you feel is not appropriate, not ethical, there is a professional way to address that. And I think that is our responsibility to address that. If we do nothing, we just let it continue. And then we do become part of the problem by doing nothing. So a few thoughts.
Thank you.
Yeah, can I add a comment to that?
Yes, please.
That was beautifully said, Doug. I have virtually nothing more to say except two little points. And this was told to me by a very old surgeon when I was attending. But he said one thing that I think we all know, and that is, no matter how busy you are, when you are talking to a patient, try to sit down, try to find a chair and sit down next to them so that, number one, you're not peering down from above them. And number two, you are giving them the impression and hopefully the reality that you are there for the long haul. You want to be able to have this conversation with them. And the second thing that he said is that if you can't find a chair, don't just sit on the edge of their bed. Ask them first if they mind if you sit on the edge of their bed, because the only thing they have control over in the hospital is that bed. And to me, that was a profound remark, because you realize how very much dependent they are on us and our system that they don't understand. And so often, whether it's in the ED or especially on the wards, you see these outbursts that probably simply reflect the extent to which they're so unhinged, they feel so alone, And they so desperately need us to help calm them down to begin that conversation again. So thank you.
Thank you, Dr. Stanton. Professor Maldonado, I wondered if you had any comments on that question, but also we've had a few questions coming in about the situation that you described of the student pointing out to his professor that he was more likely to be killed or injured from police violence than from the coronavirus. And that connects, I think, well with concerns generally about racism and what our students might be looking for. So an answer to the question that could touch on that would be super helpful.
Okay. Well, thank you. I do want to just comment on a couple of other resources that medical students, healthcare professionals should look at. So one of the things that there's all this literature, all of these studies that have found that doctors, healthcare professionals, like the rest of us, have these implicit biases and make assumptions about minority patients, assumptions that minority patients have a higher tolerance for pain, that minority patients might actually sort of be different in that there's something genetically different about African Americans, for example, or a person of Asian American, of Asian descent, that might make them more susceptible to a particular illness, which is not the case. Obviously, genetics has nothing to do with it. We should be looking at what are the environmental factors. But one great book that I just read recently, Ibram Kendi's How to Be an Anti-Racist, I think has just been, life transforming. And for us to keep in mind that there is no such thing as being race neutral, but rather you're either working, with the racist system, or you are working to be an anti-racist. There is nothing in between. You're either racist or anti-racist. You can't be neutral. But as to police violence against African Americans, I mean, that does seem shocking, right? That the fact that a young African-American male is more likely to die at the hands of a police officer than as a result of the virus. But if you think about it, the virus, although it's incredibly serious, if you are a 25-year-old, relatively healthy individual, then your risk of dying as a result of the virus is actually quite low. Even if you contract the virus, the likelihood that you're going to die is quite low. But the police kill about 1,000 individuals each year. So since 2015, about 5,400 individuals have died at the hands of police, and more than a third of those have been African Americans. Now, given that African Americans comprise 13% of the population, I mean, you could already see, sort of the racial disproportionality. And African Americans, especially African American young males, right, under the age of 30, have significant significant rates of interactions with the police, because the police are disproportionately policing minority communities, right? So people are stopped. It's hard to find an African American male who has not been stopped by the police while walking or while driving. So driving while Black, walking while Black. Every single one of those interactions, as Professor James Foreman has talked about in his book, Locking Up Our Own, each of those interactions has the potential to end up badly. And as long as we continue disproportionately policing minority communities, those interactions are going to continue to occur, regardless of how much training we provide to our police departments. So that really ties into why it is that we need less policing, and we need to address our challenges in society through mental health experts, substance abuse experts, and maybe not police minor infractions, like, I don't know, a moving violation.
Thank you. That's very helpful and ties in sort of perfectly with what you directed us to earlier about thinking of the law and the legal remedies to what in many ways the law has created or at least been a part of. So this has been a very helpful conversation, I know, for me, and I'm sure for everyone on it. We have unfortunately just about run out of time. So with our last sort of 30 seconds, Professor Johnson, since we started with you, I was wondering if you could give us sort of one takeaway, and then I'll offer some resources and we'll wrap up. So one takeaway for our students calling in.
Yeah, well, race is a social construction, and Dr. Maldonado really hit the nail on the head. And when we think about Blackness and all of the negative connotations, brownness and all of the negative connotations of that, that has been constructed over the past, centuries, few hundred years. And as a doctor, as a healthcare professional, as a human being, we have to weed those ideas, those false ideas about people who are deemed as the other, and really look at patients, look at people for people as human beings. And that's going to take work. It's going to take not just legal work, societal work, theological work, personal pains and uncomfortable work. It's going to take all of us to collectively really decipher and alleviate all of the different biases that are deeply rooted within our society, including our medical system as well. So I will encourage everybody to continue to personally reflect on oneself, on the different biases, be courageous, don't be scared, don't feel guilty, confront those, work with those particular feelings and emotions that you have within yourself in order for those particular emotions and feelings and assumptions or stereotypes that won't be actually reflected towards your patients, those individuals who are part of communities of color. So my word is be encouraged, continue to examine yourself, continue to work on yourself, on the way you think, and all of the elements and complexities of race.
Thank you, Professor Johnson, and thanks to all the panelists. I'm sorry that we've run out of time. We'll hope to continue these conversations in future sessions. I just want to draw everyone's attention to a few different resources, and we have Kelly Freeman's set up these resources. We can share those with you, and they'll also be on the page, the bioethics page that we have for folks who are looking to learn more and looking for further opportunities. We'll also list here, and in those spaces, the text that Professor Maldonado had mentioned, and as well as what some of our other panelists have mentioned. So because we're on a webinar, panelists, you can't hear everyone clapping, but we've received a number of thank yous already, so we're grateful for that. And we encourage everyone to read Kirk's book and the other books that have been mentioned. Also to follow us at Seton Hall Bioethics and at SHU Bioethics on our Instagram and Twitter, and at Hall Students for all of the students. We'll continue these conversations. Yeah, thank you all for joining us, and thank you very much to our panelists for sharing your experiences. We all appreciate it.
Thank you.
All right, thank you.
Thanks.